So thanks everybody. So I'm going to talk this evening about tranexamic acid for bleeding patients. I'm going to talk about surgery as well as trauma because I think the evidence that we have about tranexamic acid in bleeding, a lot of it's coming from we're learning a lot from surgical patients, and some of the problems that we have with tranexamic acid are similar in surgery and trauma. So just a start with a little bit of history. So a little bit of biology and then history. Um, when somebody is injured and when blood vessels are ruptured or torn, um, bleeding, the body responds by forming a fibrin blood clot. So in the 1950s, they realized that there was an enzyme in the blood called plasmin. And plasmin is like a scissors and it chops up the fibrin blood clot. Now, in this picture here, it's an electron micrograph of a clot. You see this yellow stuff. This it's like a sort of fishnet, like a web. But this yellow stuff is fibrin, and everything gets clogged in it, and that's a clot. But this enzyme plasmin is going around chopping that clot up. So even though the patient's bleeding, and it would be in their interests to have a blood clot, this enzyme's there at the same time chopping it up. And for some reason, this enzyme is sort of activated by trauma itself. So when people are bleeding and they need to clot, they're also unclotting at the same time. So this husband and wife couple in Japan in the 1940s and 50s um, tried to find a drug that inhibited this enzyme plasmin from chopping up the fibrin. Now, this chopping up the fibrin is called fibrinolysis. So this woman here is called Utako, and in the background is her husband, Shorsuke, and their surname was Okamoto. And actually, that's their daughter in the foreground because there was no childcare in those days. They had to bring their daughter to the lab. And they started off by screening a load of amino acids. They had an assay for fibrinolysis, and they screened a lot of amino acids and say, which do any of these inhibit fibrinolysis? And lysine came out as the top of the list. So lysine is an amino acid, and it's very inhibitory of fibrinolysis. Um, and they were clever biochemists, so they looked at the molecular shape of lysine, and they invented this drug called well, first they invented a drug called aminocaproic acid, which was a good inhibitor of fibrinolysis. But then they thought, well, see if we can get an even better one. And they came up with tranexamic acid. And you can see it's got a molecular structure that looks very similar to lysine. So basically, the fibrin blood clots have all of these little lysines sticking out of them. And um, plasmin comes down like a kind of lunar module and docks on these lysines. Now, when there's tranexamic acid in the patient, it blocks the docking station so that this enzyme can't latch on to plasmin and chop it up. That's pretty much how it works. Um, and they published this invention, which is a really important invention, in a rather, well, maybe you all read it, the KO Journal of Medicine. And they published it actually on the day that I was born. So I revealed my age. So 31st of August, 1962, it was published, and it had a very complicated name. It was AMCHA, but then it later got known as tranexamic acid. Now, the first one group, it was marketed for heavy menstrual bleeding and the bleeding you get after tooth extraction. But surgeons got very interested in it, and surgeons started doing randomized trials. So patients would be coming for surgery, they would be randomly allocated to get tranexamic acid or placebo, and they would see, well, look, did we give blood transfusion? Did the patient bleed a lot? And patients, and and there's really good evidence that it's effective. And this is when we got interested. I was the editor of the Cochrane Injuries Group, and we reviewed the evidence from randomized trials for the effect of tranexamic acid in surgical bleeding, and it's shown on these slides. Now, these slides show that something called the relative risk, and that's the risk of, in this, say, transfusion or mortality in those who got tranexamic acid divided by that in those who got placebo. Um, so if the relative risk, the ratio of risks is one, there's no effect of the treatment. And if it's less than one, the treatment is good. And there's a confidence interval. The confidence interval is shown by the length of the tip of the diamond, the red diamond. Now, this is like, whoa, look at that. Tranexamic acid reduces the need for blood transfusion and surgery by about a third. And it also reduces surgical mortality by about a third. Now, wow, that's really that's really incredible. This is, seems to be a highly effective hemostatic agent. And there was starting to be interest in hemostatic agents around the time that we were, well, Tim and I actually working together were planning the Crash 2 trial. And people were very interested in activated factor 7A, which turned out to be able to stop bleeding, but it actually didn't improve patient outcomes. There was a lot of thrombotic adverse effects. But so tranexamic acid was kind of a cheap generic drug then. There wasn't much interest from the pharmaceutical industries, but having seen this, we thought, wow, this is good. Let's see if it works. Um, and it really, so we did these meta-analyses of randomized trials, and what we found is that tranexamic acid reduces blood loss in surgery by about a third, um, however bloody the operation was. So imagine that you're doing some heroic surgery and people are expected to lose 3 liters. Well, with tranexamic acid, they lose 2 liters. Or you might be doing some very not bloody surgery, maybe neurosurgery or ophthalmic surgery, and the patient's only expected to lose 3 mils. Well, with tranexamic acid, they lose 2 mils. So it's like a one-third reduction across the whole range of um, bleeding severity. So it's not only the really bad big surgery, it's the small surgery as well. It reduces bleeding across the range. Now, people just carried on doing tranexamic acid in surgery trials, but their focus started to change. They thought, well, it clearly reduces bleeding, but is there a downside? So they did some big trials. This is a big trial in cardiac surgery, where the primary outcome actually wasn't bleeding. It was, thromboembolic events. Are there more thrombotic problems in patients who get tranexamic acid? And they observed the big reduction in bleeding, and they didn't see any evidence of an increase in thromboembolic events. In this particular trial, there was a slight reduction. It wasn't statistically significant, but it was on the reduction side. Uh, so no evidence that this drug causes thrombotic events. And they're still doing big trials of tranexamic acid in surgery. This is one in the New England Medical Journal a couple of years ago. Something like 12,000 patients randomized to get tranexamic acid or placebo in non-cardiac surgery. And the primary outcome was major bleeding, 9% in the tranexamic acid group, 12% in the placebo group. Big reduction, highly statistically significant. And then thrombotic side effects, thrombotic events were the same in the tranexamic acid group and the placebo group. Now, there's super strong evidence in surgery that tranexamic acid reduces bleeding. In big surgery, small surgery, across the board, safely reduces surgical bleeding. And so, I think, we thought, well, okay, what do we know about tranexamic acid in surgery? Well, it cuts major surgical bleeding by about a quarter to one third, cuts surgical blood transfusion by about a third, and there's no increase in thrombosis. And, the good thing, it went into NICE guidelines. That's okay. The problem is, though, close to half of the patients who should get it don't get it. So, the NHSBT have done audits of tranexamic acid use in surgery, and Up- Pretty much close to half of the patients who should have get tranexamic acid don't get it. So that means every day, hundreds of surgical patients, thousands of surgical patients are unnecessarily exposed to the risks of blood transfusion, and mostly without their consent. Patients don't like having a blood transfusion. It's a bit of a, it's not a nice thing to do, having someone else's body fluids injected into you. And patients would prefer it didn't happen, but they're not being offered tranexamic acid. Um, so when we saw that, we thought, well, I've got some um, colleagues in NHSBT, and we thought, look, the evidence is there. It's not an evidence problem anymore. It's an implementation problem. So we got representatives of all the royal colleges together and formed a not very boring title, Tranexamic Acid in Surgery Implementation Group, joint royal colleges. So and we wrote, editorials, and editorials don't achieve anything. That's really important to point out. But we just laid out what our stall in various editorials. This is one of the BMJ, but we did do something that was helpful. We spoke to the infected blood inquiry, and so in Britain in the 1970s and 80s, lots of patients, I think it was 30,000 patients, were infected with uh, got hepatitis B, hepatitis C, or HIV from infected blood. And it was reported, this is the biggest, it's said to be the biggest scandal in the history of the NHS, and there was calls for compensation and the government delayed. And anyway, they had a big report. And so we gave evidence on tranexamic acid use. We said, well, look, a lot of patients are getting blood they don't need to get because they're not given tranexamic acid. And to our surprise and delight, they made a very strong recommendation on tranexamic acid use. So they said, hospital transfusion committees um, should ensure that tranexamic acid is on the safe surgical checklist of every hospital, and that medical directors should report to their boards and chief executives on the extent of its use, and if it's too low, then they need to explain why. So that's still relatively new thing, and we're seeing how that will shake out. Um, but it's you've got to realize there's a there's science and there's politics, and I got a really interesting reminder of the politics recently. So there was the there's a journal called Transfusion Medicine, and it's the Journal of the British Blood Transfusion Society, and they asked if our group, our implementation group, would write an editorial on tranexamic acid use in surgery, and I said no, because it doesn't achieve anything. And they were pestering, and they said, please write an editorial. And anyway, I wrote an editorial. We wrote an editorial and sent it to them, and they said, it's brilliant. This is a brilliant editorial. We really love it. Can't wait to publish this. And they said, but can you just include a table giving the reasons why tranexamic acid is so underused in surgery? And, like lack of awareness and things like that. Anyway, so I wrote this table. I said, why wasn't tranexamic acid used in surgery? There's a lack of incentives. No, it's a cheap generic drug. No one makes a big profit from it, and so no one promotes it. When it's not used as recommended, no one knows. When it's not used as recommended, no one is held responsible. Patients prefer to avoid transfusions but are not informed about it. Medical opinions about TXA are outdated and not evidence based. TXA is safer than blood transfusion, but most doctors don't know this. Blood transfusion has a long list of adverse effects. It's quite a dangerous intervention, but for some reason, doctors think it's safe when it's not. But actually, tranexamic acid is safer than blood. And there's perverse incentives to promote blood. So the blood business is a really interesting one because they ask donors to donate blood, and then they chop it up into different parts, and then they sell the blood to the NHS. So the NHSBT, which is like a sort of part of the NHS, but it's like a sort of separate company in a way. Um, they sell blood to the NHS, and they get 320 million pounds a year. So there's not a big incentive to promote tranexamic acid. Anyway, I sent this table to the editor, complete radio silence, and so they immediately dropped it. I should have realised, but sometimes I like doing that. I say, well, just let's test and see if they will publish this. I sort of dared them. Anyway, they won't. Um, but, so that's the story in surgery. Now let's move on to the story in trauma. So I mean, surgery and trauma are physiologically similar. So if tranexamic acid reduces bleeding in surgery, you'd expect it to do similar in trauma, and it does. So we've done two big trials, big multi-center trials funded by the NIHR. The first one, Crash 2, 20,000 patients, 40 countries, and then we got this great result, but people weren't sure if tranexamic acid would work in patients with isolated traumatic brain injury. So we did Crash 3, another 13,000 patients, 29 countries. And we just got these just amazing results. So this is, again, it's the relative risk of death from all cause with tranexamic acid. If the ratio is 1, there's no benefit. If it's less than 1, there's a benefit. And so Crash 2, there's about a 20% reduction in all cause mortality if you give it within 3 hours. Crash 3, almost identical reduction in all cause mortality if you give it within 3 hours. And they've done a small study in the United States that had a very wide confidence interval, and they did a study in Australia with a very similar result. So you add up the results of these big trials, and they all show pretty much the same thing. That there's about a 20% reduction in death from all cause, early death from all cause with tranexamic acid, and it's like this. This is a p-value. It's the probability that if there's no treatment benefit, that you'd get a result like this by chance alone, and chance does not explain these results. This is the treatment really works. And the other thing is there's no increase in adverse effects. There's no increase in thrombotic risk. We couldn't find any increase in any side effect. There are side effects of tranexamic acid in very high dosage, like they use in cardiac surgery. Sometimes, for some reason, I don't know why they do it, but I think they think more is better. But they give 6 to 10 grams sometimes, and you can get seizures at high doses. But we don't have to worry about that because we don't use those high doses in surgery and trauma. Now, this is an interesting result. I mean, it's a really important result for policy. Now, let me just explain the axes. And this is showing the survival benefit from tranexamic acid. Now, this time, because we're talking about the survival benefit, a number higher than 1 is a survival benefit. And what we've got here is the survival benefit from tranexamic acid. And on the horizontal axis, we've got time from injury to the start of treatment. And on this side, we've got severely injured patients. And on the so we'll start with severely injured patients. So first of all, tranexamic acid improves the odds of survival in severely injured patients, but the benefit declines over time. You can see that this line is sloping down as time goes on. So there's a highly statistically significant reduction or increase, sorry, my mistake, in the odds of survival, but the benefit gets less as time goes on. Now, on the other side, we've got non-severely injured patients, and there's twice as many of those. And tranexamic acid is effective in non-severely injured patients. The definition of non-severely injured is at the bottom there. So just like just like surgery, tranexamic acid reduces bleeding in big bleeding operations and small bleeding operations. Tranexamic acid reduces the risk of dying if you're in a big trauma, major trauma with a high chance of death, and you've got a low chance of death. And actually, you what you can see from this, it's even more effective in the less severely injured patients. Now, I think that that should make good sense because tranexamic acid works by preventing bleeding. It doesn't do anything for the bleeding that's already happened. And in severe injury, there's more there's more bleeding before you've intervened. Whereas in less severely injured patients, there's more opportunity to prevent bleeding because they're bleeding more slowly. So tranexamic acid is effective regardless of the severity of injury. It's probably slightly more effective in non-severely injured patients. And the other point to bear in mind is there's more of them, lots more of them. So actually, a lot of the survival benefit would come if we treated less severely injured patients. Um, so, it's not just about, high speed road crash or falls from a great height. It's, you know, older adults with falls in the home, like this man's fallen off a ladder, this woman's fallen downstairs. There's a lot of potential for benefit in those kinds of patients. So well, I'll show you at the moment. Well, this is data from the Crash 3 trial. I'm sorry, I'm switching between mortality reduction and survival benefit. This is mortality reduction again, and this time a number less than one is good. And this is in head injury. So in severe head injury, there's not much benefit. There's no evidence of benefit that we can find. But if your pupils are both reactive, or if you've got moderate head injury, moderate GCS, um, it's beneficial, and it's even more beneficial if you have mild TBI. So we're getting the same picture. Well, it's partly the same data, but the tranexamic acid is slightly more effective in less severely injured patients. Now, Tim in 2019 looked at the TARN data, this big trauma audit in the UK on the use of tranexamic acid in trauma, and the Crash 2 trial reported in I think it was 2010. We had a second paper in 2011. So the the use of tranexamic acid in major trauma patients went up, but it actually didn't carry on going up. It sort of flattened out at around 10 to 15%. So a minority of patients who could benefit from this treatment actually get it. Um, this is the proportion getting tranexamic acid by their probability of survival. So you can see the very low probability of survival patients are getting tranexamic acid, but you know the patients with they've still got a risk of death. If my risk if if my risk of death was 5 to 10%, I would still be very worried. But they're not getting tranexamic acid. So at the moment, the severely injured patients tend to get tranexamic acid, but the less severely injured patients are not, and that's a problem because it works in both of them, and there's much more moderate and mildly injured people than severely injured people. Now, this is another problem. This is another problem that we need to fix. So, first of all, is tranexamic acid equally effective in men and women? Well, you should say, well, that's a bit of a silly question, and I think you're right. But let's. But this is what the data shows: it's equally effective in women and men. So these are the crash trials. Overall, add them up together. Um, there's no evidence that it's any less effective in women. So what am I lead? What, why am I making this obvious point? Well, this is the problem. So this, let me explain what this graph is showing first, but because it's quite, it's showing something really serious, I think. It's the ratio of tranexamic acid use in males and men and women. And if the ratio is 1, then that means for the same and on the bottom here is their risk of death. So for the same risk of death, if the ratio is one, males are just as likely, or females are just as likely to get treated with tranexamic acid as males. If the ratio is less than one, that women are less likely to be treated. Now, this should make us worry. If anybody has got a mother or was born of a mother, this should make you, anyway, it should make you worried because women are half as likely to receive tranexamic acid for the same risk of death from bleeding. They're, like, the chance of getting tranexamic acid is half that of a man. So it's particularly bad at low and intermediate risk, but it's still there at high risk patients. So, for the same level of risk, the same severity of injury, a woman is half as likely to be treated with tranexamic acid as a man. That should make us worried. That's a bit of a that's a problem. I mean, you know, we're not allowed to discriminate in the provision of. We're not allowed to discriminate. Full stop. We're certainly not allowed to discriminate in the administration of life-saving treatments. So this is some data. Tim Notbeam first noticed this in the data. Then we went to Tarn and did it formally, and we were really quite shocked by this. And then I've got some colleagues in Switzerland, and I said, look, they looked to see if they saw a similar thing there, and they did. So this is the underlying risk of death due to bleeding. This is men, and this is women. So low and intermediate risk, much in Switzerland, if you're at very high risk, there's no difference. But in low and intermediate risk, and a lot of patients are in that range. So this is a problem. And so this is the my colleague who works in Switzerland, um, Francois Agaron, and he worked with Tim and me to make a risk score. And so the idea was that, look, if we had clear treatment criteria, if we could have a risk score, what's your risk of death from bleeding? Apply it to everybody, and use the result of the score to decide whether someone should get tranexamic acid or not, and not let our prejudice get in the way. So he made this. This is his slide. I asked him for it earlier in this week, and I didn't realize it's got all this horror thing in it. But it's called the BAT score. I suppose he's done this so that you remember that. It's a very simple score. It's designed for paramedics because you've got to be able to make the score using parameters that are available to the paramedic at the scene of the crash. And you add up the score, and then you can the high score is a high risk, and then you can decide at what threshold that you want to give tranexamic acid. You can decide on the threshold. um, we suggested in one publication that it's a very safe drug, so the threshold should be quite low, because the outcome, you're trying to prevent death, so nobody wants even a modest or low risk of death that can be avoided should be avoided. So he's made this BAT score. He's done all sorts of validation. He's validated it in the UK. He's validated it in Switzerland. There are these different measures that tell you if a score is good. And one of them is the C statistic, and the higher the better. It's like a probability. So it's like 1 is the best you can get, and this is 0.9, which is really good. Then you've got this calibration. You compare observed and predicted risk of death from bleeding, and it's like really good, very similar. And then he's compared the BAT score with other scores that are available, and it's the one that performs the best. So the hope, what the dream is that paramedics go to the scene of a crash. They say, "Is this patient injured?" You might take a very, there's an injured. I cut my hand on a piece of glass. That all you've got to do is press on it, and they're not going to exsanguinate. The chances of dying are negligible. But if you say, like, okay, this patient's injured enough for me to, I'm going to take them to hospital. Then you can just apply the BAT score and this objective score, see if they warrant tranexamic acid use, and just let the let the score make the decision in a way, and then I think we'll probably get higher use. And I think I'm hope only time will tell, but I hope it will take away the the kind of, it's not prejudice, it's kind of stereotype of what a trauma patient is, because it used to be like high speed road crash, man in leathers and a helmet, but actually now it's more an older woman with a fall in the kitchen, and so we don't think of that as major trauma, but in older women, because age is a very strong prognostic factor, that is a major trauma. Now, the next exciting innovation about tranexamic acid is intramuscular administration and auto injectors, which are a really exciting thing, and I think they're coming soon. Um, from my perspective, it can't come soon enough. So, the Manchester Arena bombing, for those, I noticed there's some people from different parts of the world, so they might not know this, but the pop concert in Manchester, some guy goes in there, lots of kids, some young people, somebody walks in there with explosives strapped to them, blows themselves up, and there's thousands of people injured. 32 people died, and so the paramedics rushed in, and there were people bleeding everywhere. And after, it, over 1,000 people injured, 32 people died, most of them, a lot of them, children and young people. And afterwards, there was a public inquiry asking, well, could we have done? Is there anything we could have done better? Um, you know, at this mass casualty event that would have, reduced the loss of life, reduced deaths, and they considered tranexamic acid. So the report came out with this conclusion: intravenous administration of tranexamic acid. I should have said that earlier. So when we, in the crash trials, it was an intravenous injection of tranexamic acid. And according to the instructions, you're supposed to give it by a slow intravenous injection. Um, Lots of people don't, and it doesn't seem to do them any harm. But the instructions, and paramedics have to follow the instructions. It's to give it at a mil per minute. Um, so you're giving a gram over 10 minutes, and the 10 minutes seems like an eternity. And so it takes approximately 10 minutes to administer, during which the paramedic must remain in the patient. This has caused delay in the treatment of other. And then the inquiry concluded both problems could be solved by the intramuscular as opposed to intravenous TXA. And they obviously they knew what they were talking about, because we'd done work on intramuscular tranexamic acid, and to find out how well it's absorbed after intramuscular injection. And two things. One, well, here it goes. Pete, the level in the blood needed to inhibit fibrinolysis, to inhibit this enzyme that's chopping up the blood clots, is about 10 milligrams per liter. And with an intramuscular injection, you get there in 3.5 minutes. So the blood level is therapeutic 3.5 minutes after an intramuscular injection. Now, of course, it takes me more than 10 minutes to put a cannula in. And then if you doing this slow intramuscular injection, this is faster. So an intramuscular tranexamic acid, you get therapeutic blood levels faster than an intravenous injection, almost, well, I should say that's most probably, I think that. But that was in healthy volunteers, and we did another study in bleeding trauma patients, and we also got very quick absorption, a little bit longer, 4 to 10 minutes range, but really quick absorption and well tolerated, no local reactions or anything like that. Then we thought, what about shock? Sometimes shock patients don't, skin goes cold and clammy because the body diverts blood to the vital organs, but absorption from muscle is very good, even in shock. And in fact, this is blood levels when shock is present or absent. Red is absent, and black is shock present. Well, actually, you get therapeutic levels sooner in shocked patients because it's absorbed just as fast, but the excretion, it's excreted by the kidneys, and the kidneys don't work so well if the perfusion is low. So you get actually slightly higher therapeutic levels in patients with shock. Um, so it's that's another good news. So then, it's rapidly absorbed after intramuscular injection. Unfortunately, there's a lot of war in the world, and the militaries everywhere have become very interested in tranexamic acid auto-injectors for use on the battlefield. But of course, if they can be used on the battlefield, they can be used in civilian trauma care as well. And so the problem about getting tranexamic acid into an auto injector is that it's a 1 gram dose, and it's 10 milligrams per mil. So you've got to give 10 mils. Now, 10 mils doesn't work in an auto injector, but companies now have concentrated tranexamic acid. So you can get a gram in 2.5 to 4 mils. And so now we've got concentrated tranexamic acid uh, solutions that will go into an auto injector. And um, I spoke to Phil Cowburn, who's leading this for the NHS, wrote to me today to say that this is, there are companies already going to the MHRA with tranexamic acid in auto injectors, and his message was very upbeat. This is coming. This is coming very quickly, and because of all of this, you know, Ukraine and all of that sort of stuff, it can't come soon enough. So that's an exciting thing. So when we got the results of the CRASH 2 trial, I didn't know anything about the history of tranexamic acid. I said, where did this drug come from? And I tried to find out who invented it, and uh, I found out it was invented in Japan. Luckily, my wife's Japanese, and so she helped me with to track it down. And here she is. So I showed you a picture of her in a lab when she was 30. Well, here she's 94. When I tracked her down, she was 94. She was still working, still meeting with her researchers. And I presented her with a certificate on behalf of the CRASH collaborators, and she was really happy. She was really interested in the other big trial we were doing, the woman trial, because she invented tranexamic acid, hoping it would be a treatment for postpartum hemorrhage. Um, and unfortunately, she never lived to see the results. She died 2 weeks before we finished the woman trial. Um, but we got the same result. We got a 1/3 reduction in death due to bleeding in postpartum hemorrhage with tranexamic acid. So she never got to see the result, but she told me, I know it's going to work. So maybe she didn't need to see the results. So it's kind of, it's taken quite a long time to get this drug to patients, and we're still not as successful as we should. There's a bit of work to be done, and it's really important work, because the thing about this is, you know, I know that there's lots of paramedics and trauma doctors on this call, and you do urgent things all the time, life-saving urgent things all the time. But if you can fix the system so that, if you can work on the way the system works so that more patients get pre-hospital tranexamic acid, and not just the severely injured, across the whole range of severity, you'll be you're saving lives. Even if you can do that, you'll be saving lives even when you're not working. Even when you're on the weekend, what you've done, it's a really highly efficient way to be a good doctor or paramedic, because, yeah, just like we can see one patient, one patient, one patient, but if we can change the system so that we've got that the patients get what they should get when they should need it, that's a big deal. So thanks for listening. I'll stop there.
Wonderful. As like posh flushes. I love that. What a comment. But thank you so much, Professor Roberts, for giving us a fantastic insight into the wonderful world of TXA. And let me just make sure that I've done it again where I've not exited the full screen, so I can't actually share my screen. Now we shall be able to. So before I hand over to Tim, who is going to lead on the Q&A section tonight, because there are words and there are words in the Q&A that I do not understand. I just want to draw everyone's attention to our next webinar, and that's going to be taking place this time next week. So 8 o'clock next week, we have Dr. James, Kid Confident, Nayart, joining us. Always fantastically popular events. He always gives such a wonderful presentation, and we all love Kid Confident here. And next week, he's going to be speaking to us all about pediatric head injuries. So if you do fancy joining us, either head over to our website or scan the QR code that's on your screen now and sign up. And I know we're actually getting pretty full with this one next week. It's another really popular one. So do make sure you join us early, because we have a limit of 1,000 people. So what I'm going to do is I'm just going to explain the QR code that's on the screen now before I knock myself off audio and video and hand over to Tim and Ian to talk through the Q&As. And a lot of questions have come in tonight, which is actually wonderful to see. If you are not a member of Trauma Care, this is your chance to scan the QR code that's on your screen and you can purchase a certificate for $199. However, if you or you can follow the link that I'm literally about to copy and paste into the chat as we speak. So you can follow that link, or you can scan the QR code that's on your screen now, and that will take you through to purchase a certificate for $199. However, we have had an abundance of people sign up to membership tonight. So from the bottom of myself's heart, for everyone at Trauma Care, thank you so much for supporting us, for joining us this evening, and for signing up to become a member. You guys and previous members, people who are already members, do not scan this QR code, leave it be. You will get your certificate free of charge tomorrow morning. And if you do fancy becoming a member, you've got until 11 a.m. tomorrow, which is when I'll be sending out the certificates. So that being said, I'll leave the screen up so everyone has a chance to scan the QR codes. But Tim and Ian, whenever you guys are ready, I will hand over to you and we can go through the questions.
Thank you, Anna. Ian, I'm wondering if you have about the next 2 hours free, because we've got loads of questions here.
I'll stay as long as I can.
And you and I talking about tranexamic acid. This is going to go on most of the night, but Anna will probably cut us off at some stage. So let's dive into some of these. Starting off with perhaps some of the ones around the evidence. There's an interesting one here from Ingrid, asking about the sort of separation of severely injured and less severely injured patients, in particular about GCS assessment, and at what stage that was made in the patient's journey, and whether
that's a good question.
If you're measuring pre-hospital versus in hospital, you're going to have a difference in your score, or how you should proceed.
Well, the two crash trials were hospital-based trials. So the crash 2 trial was in 40 countries around the world, but it was in emergency departments. So the reason that we knew that tranexamic acid had to be given at the scene is that when we looked at the effect of tranexamic acid by time to treatment, it was much more effective when given early. So even if it's a hospital-based trial, some patients get to hospital within minutes, or within the first hour. Some patients took a long time to get to hospital. But if the ones who got it really quickly had a much better treatment effect. So it wasn't a pre-hospital trial, but we still know it has to be a pre-hospital drug because of the treatment benefit. The only big pre-hospital trial was this patch trauma trial in Australia, where they did give it, paramedics gave it at the scene, and they similarly got quite a large treatment effect, mortality reduction.
Yeah, thank you. And there's a sort of theme of some questions around thromboembolic events following from tranexamic acid use. Danny asking that in the women that are taking tranexamic acid for menorrhagia, is there evidence of PEs and DVTs? And does the surgical literature really apply to trauma, where there's a lot more sort of small vessel damage, endothelial damage, and that sort of thing that most surgeons make?
Yeah, we randomized trials of tranexamic acid in surgery and trauma do not find any evidence of any increased risk of thromboembolic events. So we've done meta-analyses with more than 100,000 patients, and there's just no evidence of any increased risk of thromboembolic events. Now, I know people say, well, how could that possibly be? You know, it helps it helps bleeding, and so people tend to think of bleeding and thrombosis like a seesaw. If it reduces bleeding, it must increase thrombosis. Well, I'll give you some other things to bear in mind. So, first of all, what our research shows that one of the biggest risk factors for thrombosis is actually bad bleeding. So actually, bleeding is a cause of thrombosis. So if you can prevent bad bleeding, you can actually prevent. You might be able to reduce thrombosis as well. Secondly, and this applies particularly in surgical trials, is that blood transfusion is prothrombotic. Blood transfusion um, it causes a bit of a immunological reaction, and your blood gets a little bit more sticky. So blood transfusion does seem to be prothrombotic. So if you reduce the need for blood transfusion, you could reduce the risk of thrombosis that way. And of course, if patients get better faster because they didn't have exsanguinating hemorrhage, they're up and walking around and ambulating and reducing their risk. So people always think of the ways they expect that it should, but there's lots of mechanisms through which it might not. And the thing that should be driving us is the data. And the data show no evidence of increased risk of thromboembolic events. And coming back to the original question, women on tranexamic acid, they often take about 3 grams a day whilst they're menstruating. And the randomized trials, they're not huge, but they don't show any evidence of thromboembolic events. In Japan, it's sold over the counter for headache. It has a slight anti, uh, a slight analgesic effect. So yeah, my wife was taking. What are you taking that for? She was taking it for a headache. So it's not a dangerous drug.
Yeah, lots and lots of usage worldwide. It's an old drug. We know it very well.
Yeah.
And there's a couple of questions around this difference between men and women in whether they get tranexamic acid. Why do you think this is? Is this just prejudice on the part of paramedics, or what's going on here?
Oh, the truthful answer is I don't know. So I'll skirt the answer by saying what Tim Nutbean thinks. He thinks our concept of trauma is kind of gendered. I've tried this out at meetings, and I say to people, right, I want you all to imagine a trauma patient, and I want you to tell me, just imagine the scene. Tell me who's there, where they are, what they're wearing, and you will often get they disproportionately think of a man and a young man, and they're on a road, or they've got a knife in them, or they're outside a club or a pub, and you'd be surprised how rarely people conjure up an 80-year-old woman in a nightie on the bedroom floor. So Tim thinks that our major trauma conjures up images of young men in a high-speed road crash, and for half a century, that's what major trauma was. but it's changed. That's the thing.
Yeah, I think it's now 58% of major trauma is older, fall on one level, but still with the same severity of injury. And, I think we see so many older people fall on one level, we get a little bit complacent about it, and they're really difficult to spot with
Yeah,
those patients. So that's the low velocity, low energy transfer major trauma versus high energy transfer major trauma that we've talked about in previous seminars.
yeah,
There's lots of, now quite a few questions around the formulation and the giving of tranexamic acid. So, you know, just the bolus followed by infusion, 1 gram to start with, 2 grams to start with, given IV or IO. What's best?
okay. So the let's think. So there's the 1 gram, 2 gram question, and I don't know the answer. I don't think there's any good evidence that 2 grams is better than 1 gram. So in the crash trials, we gave 1 gram immediately, and then we gave 1 gram over 8 hours. And we did that because we thought, well, supposing you know bleeding is really bad, and they've all they get a lot of blood transfusion, and they lose all the tranexamic acid. But I think what we've learned from the pathophysiology of trauma, um, and actually Tim's done a lot of this work. I think he coined it as a fibrinolytic gap, so that you get this initial burst of fibrinolysis at the shortly after the moment of injury, and then the body's own antifibrinolytics wake up at about 3 hours. But in that first 3 hours, there's a gap where you've got kind of unopposed fibrinolysis. I think the first 1 gram is doing the heavy lifting, and so it's getting that 1 gram in, or 1 gram or 2 grams. I don't really care. I don't think it matters, but get the first dose in really quickly. I think that's the important thing. So 1 gram or 2 grams, I don't think is a big deal. And so I think you can do what you want. Um, it's getting the first dose in quickly. And so what's the best route? So um, I I think that my own view, based on the evidence that I know of, is that the intramuscular route is the best, because you get therapeutic. You don't have to waste time putting a cannula in. You get therapeutic levels really quickly. And you could just smash it in, and then forget about it and do all the other things that paramedics need to do. So I think the intramuscular route is the best. Um, Intraosseous, I don't see much need for it. When you can, yeah, I would always have. I've had several intraosseous injections during the time of Ebola. Um, um, I got the impression. I came to the conclusion that patients weren't getting fluid resuscitation because people were afraid of getting intravenous access to these patients. So we did a little video showing all the different routes you could get it, and so Tim Harris, professor of emergency medicine in the Royal London, gave me. He drilled one into my shoulder. He fired one into my tibia, and it hurts. So I wouldn't. I've also made training videos for intramuscular tranexamic acid, and got my daughter to inject me into my leg. She's a doctor, and that didn't hurt at all. So I would go for intramuscular any day of the week. I I think that's the dose
Yeah.
route questions.
Yep. No, that sounds good. Now, there's a lot of questions, I think, coming from police, medics, mountain rescue, and
Yeah,
others about the classification of the drug.
yeah,
Stuff that I don't think I probably understand enough about, which is whether it's on Schedule 19 HMR, can be given by non-clinicians to
yeah.
emergency services. I know you've had some dealings with this. Where are we with that?
Okay, so after the Manchester Arena bombing inquiry, um, there was a recommendation, and so the NHS has to take seriously the recommendation, and so they've established an implementation group. And the person that I mentioned, Phil Cowburn, earlier in the talk, he's the kind of leader of that, and so he's liaising with emergency response people and the companies developing the auto injectors. And he, in his message today, I can't get it because I can't switch to it quickly, but he mentioned that um, there are moves afoot to get it onto Schedule 19.
Hmm.
There are different schedules, but I do remember the message today. He said Schedule 19. And I think that means that police officers, mountain rescue people, uh, certain people should be able to do it. And when it's an auto injector, that would be really good because police are often the first people at the scene. Um, firefighters as well.
Yeah. Now, one of the things I noticed on your graph from Switzerland is that there seemed to be quite an underuse of TXA there as well. And there's a comment in the chat about from Juan Salamanca saying that he's got a subjective opinion about underuse in Germany too. And I
Yeah,
just wonder,
I think it's
this
underused.
seems to be it's not UK. It's not something to do with the
It's
UK
not.
ambulance services. That seems
No.
to be general.
So this guy Francois Agaron, he was a PhD student with me in London, and he now works in Switzerland, and so that's why he's validated his BAT score in Switzerland. But yeah, it's pretty much the same issue there. It's the very high end severity that gets tranexamic acid, but there's a huge lump of patients who would benefit from it. Um, and the thing is that really, really major trauma is relatively rare. Um, they get a big benefit from tranexamic acid, but there's not many of them. And actually, it works out that a lot of patients getting a modest benefit actually can add up to more lives saved than a few patients getting a big benefit.
Yeah.
So I do think we're not using it properly yet.
There's, I think, 3 or 4 questions around why give tranexamic acid over 10 minutes as the initial. Why not just give it as a bolus? Because 10 minutes is a long time to stay there. And I know both of us are thinking the same thing, but go
Where do these
on.
things come from? Where do they come from? So, like, I've tracked it down to so the drug was invented in Japan, and then it was given the patent was given to a company called Mitsubishi. Then Mitsubishi gave it to Upjohn, and then Upjohn was taken over by Pharmacia, and then it eventually got to Pfizer. And so I saw the dossier that was given to Pfizer, that Pfizer gave to the FDA to get a license for the drug. And I thought, where does this 10 minutes thing came from? And it was one patient felt dizzy while receiving the intravenous injection. And then 10 minutes arises.
Yeah.
And then it goes into these summary of product characteristics, and it's there for life. But I
Uh,
don't think there's any good basis for it. I really
yeah.
don't.
I mean, we had a big discussion about this when we were designing the Crash 2 trial, didn't we? And the conclusion was that we probably just had to stick with what was in the SPC because it wouldn't be acceptable otherwise, and licensing and all
Yeah,
sorts of trouble. But I don't think that anyone involved with doing the trial really believes that the 10 minutes is important.
nobody at all. Yeah.
Um, we're probably going to have to start wrapping up fairly soon.
Last two
So
questions. Last two questions.
last 2 questions. Okay. Somebody asked for an update on the Crash 4 trial.
All right. So just for the bit of background, Crash 4, I told you that actually tranexamic acid looks to be most effective in mild TBI. So mild more than moderate, more than severe. And we think that's because you kind of bleed more slowly in mild TBI, and so there's more opportunity to prevent it.
Yeah.
So the interesting thing is there's nothing mild about mild TBI. It's a real misnomer, especially in older adults. Older adults do very badly with mild TBI. They get intracranial bleeds, they die, they get, I don't know, dementia, and there's a lot of disability and a reasonable amount of death in older adults with mild TBI. NICE guidelines recommended tranexamic acid for moderate and severe TBI. but not mild. So we're doing a trial in older adults with mild TBI to see if tranexamic acid improves outcome. And we've got about close to 3,000 patients randomized. It's a harder trial to do than I expected. And part of the reason is that we want them to be treated within 3 hours. There's literally tens of thousands of patients with mild TBIs, but they get to hospital really slowly. If an older adult calls for an ambulance, often the ambulance doesn't come for 6 hours. So you've missed the window of opportunity. But thanks to a lot of paramedics in the UK, we've got pre-hospital randomization, and the trial's doing much better now. Most ambulance services in the UK are taking part, and numbers are going up. So I think it's really good, and we'll get an answer when we get to 5,000. So we're nearly 3,000, and we've got 2,000 to go.
So we've got loads of questions still, but we probably ought to wrap up on a last question. Several people posting that their ambulance service policy is that tranexamic acid should only be given to critically ill patients, if there's a blood pressure less than 90 and so forth. What do you think about that as a policy?
It's not good policy. I think we have to change that. It's you see, in the CRASH 2 trial, we had a real range of severities because the inclusion criteria are really simple. Adults with or suspected to have significant bleeding. And we didn't really, you decide what significant bleeding is. So we got big range of severity, and it's equally effective regardless of severity. But I don't know, there's overcautiousness, and so a lot of patients are missing out on the benefits.
And there's a lot more moderately injured patients than very severely injured patients. So actually, we're missing probably the majority of the benefit.
I think so, yeah.
If we just limit it to the very severely injured.
I do think so, yeah.
Excellent. Look, I think we ought to stop the questions there. We could go on all night, but we'd probably lose. We'll have an audience of 2, and Anna will be asleep. So I think thank you very much indeed for answering those questions.
Well, thanks for you for inviting me, Tim and Anna, and also to the audience. But there's a real job of work to be done. It's actually, if you want to change the world, you're going to have to do it. So take it back to where you practice and try and change things, because you'll do a hell of a lot of good.
Absolutely. Oh, incredible. No, thank you both to Tim and Ian for such an engaging night as well. I think it's probably the best word I can describe it as: engaging. It's informative. It was relevant as well. And to see, I think there were 33 questions that came in, which obviously that would just be a whole presentation in itself. And however many more in the chats, and really, really good discussions going on as well. So thank you both for joining us so much this evening, and for Tim for taking the weight off my shoulders of not pronouncing bizarre words and being able to group questions together as well. And thank you, of course, to everyone else for joining us this evening. The final big thank yous, as always, though, do have to go to our trauma care sponsors. We've mentioned Slater and Gordon already as our premium sponsors, but our secondary sponsors, QualSafe, they are our first aid sponsors. And if you've enjoyed tonight and you happen to be in the volunteer, the first aid, the CFR sort of stratosphere, then this is a website that you should definitely check out. If you go to qualsafe.org, they've got loads of fantastic courses available for you to up your knowledge, get those valuable certificates, and just become the absolute top of your game. And of course, Laura, I do know you're in the chat tonight. I did manage to spot you. So the lovely Laura Criddle from TCAR and PCAR are here tonight as well. They're a wonderful, wonderful foundation that do lots of things to do with sort of how to do the care after resuscitation, a lot of trauma training that's based around nurses. So if you happen to be an AHP or a nurse, this is a great site for you to check out. They do have a UK website, even though they are based over in Oregon. So do scan the QR code that's on your screen now. You can find out more about all their courses that they've got going on as well year round. And Galen, as always, I'm not allowed to, I still haven't taken that double thing off, but as always, I'm not allowed to say much about Galen because I'm not trained and they're a pharmaceutical company. So I'm sure you can all understand those rulings there. However, if you do want to find out more about our wonderful, long-standing and good friends over at Galen, scan the QR code that's on your screen or go to galen-pharma.com. Click on I'm a practitioner and you can find out more about all the things that they have. And that is absolutely everything from us three this evening. Again, I've seen once more people from all over the world, all over the country have been with us. It's absolutely incredible. What a fantastic audience. And to get so many questions that we actually couldn't get around them is rare. So thank you both very much. The biggest thanks, of course, to our audience, to Tim and to Ian. So wherever you are in the world, as always, take care of yourselves, take care of your loved ones, and enjoy the rest of your evening, folks. Good night, all.
Bye.